Okay, so on behalf of the co-investigators, I'd like to thank the conference organizers for the chance to present these data. This is a phase 3 randomized clinical trial, and it's a comparative clinical trial comparing co-formulated bictegravir FTC-TAF, hereafter referred to as BF-TAF, and dolutegravir plus FTC-TAF, hereafter referred to as dolutegravir plus F-TAF. About 600 treatment-naive patients were randomized 1-to-1 to receive either BF-TAF or dolutegravir plus F-TAF or matching placebos. So everybody took 3 pills a day. They were eligible if they had viremia, treatment-naive, an estimated GFR greater than 30. Hepatitis B and C were allowed, and they were enrolled in multiple clinical trial sites in North America, Europe, Australia, and Latin America. There were the standard stratifications for HAV RNA and CD4 cell count, as well as geographic region. The primary endpoint was proportion less than 50, percentage less than 50 at week 48, using the FDA snapshot analysis, and that was advanced automatically because I didn't do it. So if yours is an auto-advancer, please turn it off. Anyway, I want to mention a little bit about the baseline characteristics. I don't have time to show the full table. It was about 88% men, about 50% either black or Hispanic. The baseline HAV RNA was about 4.4 log, and CD4 cell count was about 440. So let's take a look at the primary results. 89% of the BF-TAF arm and 93% of the dolutegravir plus F-TAF arm had HAV RNA less than 50 at week 48. The lower end of the 95% confidence interval of the 3.5% difference was minus 7.9, and that is within the non-inferiority threshold. As a result, BF-TAF was non-inferior to dolutegravir plus F-TAF. Importantly, very few patients experienced virologic failure in the study. Very few underwent resistance testing as a result, and there was no resistance detected to any of the components of the treatment regimens in either study arm. There was several sensitivity analyses done, including a per-protocol analysis. The per-protocol analysis demonstrated 99% and greater than 99% results, respectively, for BF-TAF and dolutegravir plus F-TAF. This analysis excluded people who were missing and also excluded the lower 2.5 percentile of the patients who were non-adherent, lower 2.5 percentile of adherence. You'll note the primary difference is in this category, HAV RNA greater than 50 copies. I'll show that in a little more detail in this table. You'll see there are 14 patients in the BF-TAF arm and 14 patients in the BF-TAF and 4 patients in the dolutegravir plus F-TAF arm, and 11 of the patients in the BF-TAF arm fell into the category of discontinuation due to other reason and last viral load greater than 50 versus 3 in the dolutegravir plus F-TAF arm. And we'll now take a greater look at those study subjects. In the BF-TAF arm, 6 of the 11 study subjects, for reasons that are varied and not clear, all stopped the study after enrollment, but never returned after their baseline follow-up visit. So you'll notice a variety of these individuals ended up moving. One was incarcerated. Some decided not to participate at all. So all the data we have is their day 0 visit when they were randomized and took their first medication. There were no study subjects in the dolutegravir F-TAF arm who had the same status. So additional findings in the study was that BF-TAF was safe and well tolerated. There were very few study discontinuations for adverse events in both study arms. The lipid changes didn't differ between the study arms. There was less of a decrease in estimated GFR for BF-TAF than dolutegravir plus F-TAF, but there were no renal adverse events that led to treatment discontinuation or any renal adverse events of note at all. I will encourage you to look at the full poster, and you'll see that you'll see additional results. So to conclude, virologic suppression at week 48 was high in both arms. BF-TAF was non-inferior to dolutegravir plus F-TAF, and importantly, none of the patients in the study either discontinued due to lack of efficacy or discontinued with treatment-emergent resistance. The data do reinforce the non-inferiority of BF-TAF versus dolutegravir-based regimens, phase 3 data comparing BF-TAF to abacavir, 3TC, dolutegravir were presented yesterday by Joel Gallant. And I just want to also say that in that study, they did not have this imbalance in the study subjects who left after the baseline visit. So I think I got it in under 5 minutes, Jürgen, and thank you very much.
The session is open for questions. Laura.
Hello, Laura Waters from London, UK. Just a quick question. Yesterday you showed there was a significant difference in nausea rates. Could you comment on the rates of nausea in this comparison?
So this comparison was a direct bictegravir versus dolutegravir comparison, whereas yesterday's was abacavir, lamivudine, dolutegravir versus TAF, FTC, bictegravir. And so in this one, there were not a significantly different rate. There was a little bit more nausea in the dolutegravir arm, but not significant.
Paul Andrew Cassidy. There's a lot of non-inferiority going around here. Is there any clinically meaningful, significant difference between these two likely first-line regimens?
So it may not.
Is there any superiority?
Yes, actually, yesterday, Monica Gandhi asked the question about a difference in drug interactions. A very commonly used drug is metformin. This bictegravir has less of an effect on metformin levels. In fact, not a clinically significant one than dolutegravir. But they appear to be very similar in clinical studies thus far. So they both have an in vitro and so far in vivo very high barrier to resistance, with resistance being extremely unusual in clinical trials. And now we know in dolutegravir clinical practice.
Any more questions? I have one question because this is one of the first trials which at least aimed successfully at having a little higher amount of women enrolled, right? You had 20% women in this trial?
No, 12%.
Okay. I withdraw my question. Thank you. Sorry. All right. No, then I withdraw my question. Any other questions? No. Okay. Thank you very much, Paul. So we're going to move to the next presentation, which will be given by Randolph Matthews from Merck. His presentation is titled "Single Doses as Low as 0.5 milligram of the novel NRTI MK8591 suppress HIV for at least 7 days."
Good afternoon, and thank you to the organizers and to the co-chairs for the introduction. It actually is NRTTI. It's not a typo there. Since we have very little time, I will refer you to the poster, and as many of you probably know, the poster numbers are virtually impossible to decode. So the poster is near room 241. So that should be easy to find. So thanks again. So I'm going to talk to you about our phase 1b proof of antiviral efficacy trial of MK8591. Essentially, as you can see here, an evaluation of tolerability, PK, and antiretroviral activity of MK8591 in treatment-naive HIV-1 infected adult subjects. So I believe many of you have probably heard about 8591 previously, so I won't dwell on this for too long. It is an NRTTI, or an NRTI-like compound with a novel mechanism of action. It has a high potency and a high barrier to resistance in vitro, a long half-life in preclinical studies and in healthy human subjects so far, and has been generally well tolerated in our healthy human subject trials so far. And so in this particular trial, it's a single-dose monotherapy study. It's open label, multiple panel study. We gave doses of 0.5, 1, 2, 10, and 30 milligrams. It was administered once orally per subject. Subjects were strongly encouraged to initiate standard of care therapy after either 10 days for the higher doses or 7 days for the lower doses. So the objectives were to look at tolerability in the HIV-1 infected subjects, to assess PK, both as the parent compound in plasma and as the active triphosphate in PBMCs, peripheral blood mononuclear cells in these subjects. Of course, the main goal was to look at the degree of viral load suppression post-treatment, and we were really looking to see the lowest dose at which we would see at least a 0.5 log 10 drop from a placebo-corrected baseline. And then we were also interested in looking at the PK/PD relationship between the triphosphate and the viral load decline levels. So it was generally well tolerated as a one-time dose in the HIV-infected subjects. There were adverse events in 29 of 30, but only 27 out of the 30 had treatment-emergent adverse events. There were no severe adverse events and no discontinuations due to an AE. All of the AEs were mild or moderate, and importantly, there was no relationship between dose and frequency or the severity of AEs. So there's a table here showing the most common treatment-emergent AEs, and as you can see, it's headache, diarrhea, and eczema. And there were no clinically significant changes in vital signs, EKG parameters, or in lab safety findings. So here we have the viral load decline examination, and as the title suggests, we had single oral doses as low as 0.5, leading to a viral load suppression. As you can see from the graph and the table, at the top dose of 30 milligrams, we had a drop of over 1.5 log, and even at the lowest dose, the 0.5, it was over 1 log drop at 1.18 placebo-corrected. There was mutant screening performed in the post-treatment samples. Of those samples in which amplification was possible, which was 17, none of them had a detectable mutant. And then just to summarize, all the dose levels here led to a robust viral load decline after the one-time oral administration of MK-8591. And I believe I'm well below 5 minutes there. So happy to take questions.
All right.
I'm just going to shout a question.
Yes. Joe?
Joe, you're on. Was there any censoring of that viral load? Did any of the participants go below the limit of detection, or can we assume a dose response there?
It's a pretty accurate dose response. There may have been a subject or two at the top panel that got below the limit of detection, but in general it wasn't an issue.
Yeah, sure.
Is it a prodrug? This compound need a trisphosphorylation in the cells?
Yes.
So, have other nucleoside inhibitor? I was wondering if there is a competition between these two compounds.
So that's been looked at in vitro, and there has been, with a number of different compounds, and no, there was no competition with any of the other known NRTIs.
So if you look at the doses, and since there still seems to be an increase in the decline with not too much between 10 and 30, does that mean you're not going to explore any higher dosages? Was there any, and can you comment on the preclinical safety data?
So the preclinical safety has been largely unremarkable. There was nothing that particularly made us certainly not want to go into clinical development. The studies in human subjects, we've looked at higher doses, actually one-time doses as high as 400 milligrams with really very little issues with regard to safety.
Marta?
Yeah, sure.
So you said subjects were encouraged to start antiretroviral therapy. Did anybody not start? Did you have the chance to follow what happens to viral load after day 10 in the people who chose not to start?
So in fact, there was one individual who did not start, and the viral load in this particular individual did remain low for quite some time. I will say that we do not understand everything that was going on with this one particular individual, and so it's a little bit hard to conclude much of anything, but he did have a pretty prolonged suppression of viral load after stopping, after just the one dose. That was at the 30 milligram dose.
Any more questions? If that's not the case, thank you very much.
Next presentation will be done by Marta Bofito from London about the kinetic, pharmacodynamics, and pharmacogenomic of efavirenz 400 milligrams once daily during pregnancy and postpartum.
Thank you very much. Good afternoon. So yes, I'm going to present the data on behalf of my co-authors on the pharmacokinetics, pharmacodynamics, pharmacogenomics of the lower dose of efavirenz, 400 milligrams once a day, during pregnancy and postpartum. So just a bit of background. As you all probably know, the Encore 1 study showed that efavirenz 400 milligrams when given with TDF and FTC is non-inferior to efavirenz 600 milligram. And there's a school of thought that is looking at antiretroviral dose reductions as this, when they're possible, may translate into greater benefits for more individuals living with HIV and reaching higher number of patients, and therefore compensate for finite global manufacturing capacity and increasing demand. And this has been shown for efavirenz because, again, being non-inferior at a dose of 400 versus 600, it can be brought forward. So the WHO guidelines, in fact, mention 400 of efavirenz as a possible third agent in first-line treatment. However, there is a disclaimer because there are no data available for during pregnancy. And so the objective of this study was to investigate the pharmacokinetics of efavirenz 400 and also the efficacy and the pharmacogenetics at the level of cytochrome P452B6, which is the main metabolic enzyme for efavirenz, in women living with HIV, pregnant women living with HIV during the third trimester and postpartum. So women living with HIV that were pregnant and were undetectable on TDF, FTC, and efavirenz 600 switched at baseline to efavirenz 400 and to protect the women, to make sure that it was safe to give them a lower dose of efavirenz during pregnancy, we performed therapeutic drug monitoring approximately 12 hours post-dose every week and viral load every other week. Steady-state pharmacokinetic profiles and polymorphisms of interest, so the 516 and the 938, were also studied. So this slide shows the pharmacokinetic parameters and the full profiles. So in the table, you can see the main pharmacokinetic parameters measured during the third trimester and postpartum, and the geometric mean ratio of third trimester over postpartum. So the maximum concentrations, the CTRAF, and the area under the curve during the third trimester were 7, 27, and 16% lower during the third trimester versus postpartum. But what is important is that if we look at the concentrations measured, these were all within the range of those measured for efavirenz 600 during pregnancy. And also, there were within those ranges that were demonstrated to be effective in the Encore 1 study PK sub-study. The graph below shows the steady-state concentrations, area under the curves, measured in blue during the third trimester with the 95% confident intervals, and in yellow during postpartum. And the red line indicates the minimum effective concentrations that we considered during the study, which was 800 nanogram per mils. So this is the last slide where I wanted to show you all the therapeutic drug monitoring results. And you can see that there are some women that have very high levels, but only two, those two in orange, are actually slow metabolizers. So they are carriers of the 156TT polymorphism. The red line indicates the geometric mean of all the TDM levels that have been performed over 3 months. And we still really don't know what the efavirenz cutoff, what the optimal concentration is. So to confuse you, I put a lot of lines of different colors there, indicating all potential minimum effective concentrations. So in blue, it's the Marzolini et al., published quite a while ago, in 2001, that looked at retrospectively what concentrations of efavirenz 600 we should have there to ensure virological response, and said 1,000 nanogram per mils. But actually, when we looked at the PK sub-study of ENCORE 1, concentrations much lower than that seemed to be associated to response. And those are the black lines there. So between 470 nanogram per mils and 760 nanogram per mils. And that's why during the study we chose 800 nanogram per mils as a safe concentration. And then there is also one extra line, which is the pink one, which is the lowest trough concentrations measured by Scholwick et al. When they looked at the pregnancy. I'm not done. The pregnancy data for efavirenz 600. And the conclusion which was written there is that all the women in the study maintained an undetectable viral load, no newborns had HIV, and we think that actually 400 nanogram per mils is safe in terms of drug exposure during pregnancy, including the third trimester. Thank you very much.
The session is open for discussion. Paul?
So Marta, has there ever been any of these changes in concentration of any of our antiviral drugs late in pregnancy that has had any clinical impact whatsoever?
Maybe not. However, you need to understand that the changes of the concentrations may be due to different reasons. So you can't just say, well, then any third agent, mainly any antiretroviral is fine. Because if we look at the changes that occur during pregnancies, they are very variable. So for example, the big question is always about darunavir. But if it is the total concentrations of darunavir change during the third trimester because of a protein binding effect, so there's more free drug, it's probably not clinically significant. So pharmacokinetics is very important. I can't say the opposite being me, but pharmacodynamics is also very important. So the fact that these studies are done in people living with HIV and the fact that an undetectable viral load is maintained is your real answer. But I think we need to make sure that we don't apply this to every third agent, because the new drugs need to be studied in pregnancy properly.
Polyclonal HIV base. Marta, this actually is a sneaky question for Marco, who's sitting at the front. What do you think the WHO should do with those data?
Good question.
And Marco can help you.
Marco, sorry, your problem. Do you want the microphone?
So I don't know whether Marco wants to address that, but I want to ask you something else, because obviously the results depend also on variation. And the question is, so how many women were in this trial? I just didn't get that. And was there a good distribution between different racial entities? And did you have enough different body weights in there? I mean, just to be, how secure can we be with the results? In a certain way?
Because of the very wide inter-individual variability of the results, it's a very, very good question. The very wide inter-individual variability is due to high levels. So if there were people that were dropping levels all the time and were taking the whole geometric mean down, then we would worry. But the reason is there's all the women, no woman was excluded because of low levels. The levels were maintained above 800. In the majority of women, above 1,000, the old traditional cutoff. So the variability is due to women that are overexposed even to 400. We didn't see it looking at 516 and 938, but hopefully we will do more pharmacogenomics analysis to explain that.
Do you have some information or result about how did you say, the transplacental passage of the efavirenz in this cohort, on the cord blood? Do you measure efavirenz?
Yes, we have measured it when possible, but I don't have the data yet. But we will be in the paper.
Great. Any final questions, comments from WHO? No. All right. Then.
No?
All right. Thank you very much.
We skip for the next presentation. Dr. Abu is the global medical lead for dolutegravir in VIV institution. The presentation will be the sub-study of SWORD 1 and 2, switch from tenofovir-containing regimen to dolutegravir plus rilpivirine, improves bone mineral density and bone turnover markers over 48 weeks. Thank you.
Thank you very much. I present on behalf of Grace McComsey, who couldn't be here today, and of course on behalf of the study teams and investigators. I would like to signpost you to look at this poster for more details also, but like my colleague earlier, I'll be even less specific and say it's at a corridor somewhere on the second floor. Can't be any more specific than that. So at the previous conference, at the CROI conference earlier this year, we presented primary safety and efficacy data from the SWORD 1 and 2 studies. At that time, the data showed that a switch to dolutegravir plus rilpivirine was non-inferior to the standard antiretroviral therapy up to weeks 48, with very high efficacy rates of 95% in each arm of the study. Now, this DEXA sub-study is designed similarly to the parent studies, and individuals who are on a tenofovir-containing regimen were randomized to be switched either immediately to dolutegravir plus rilpivirine or stay on the current antiretroviral therapy. DEXA scanning was done or is done at baseline, weeks 48, 96, and 144. The primary endpoint is the change in DEXA in bone mineral density between baseline and weeks 48 and I'm sorry about this. DEXA change in bone mineral density between baseline weeks 48 compared between the arms at the hip, and a secondary endpoint is the same reading at the lumbar spine. So I'd like to point out important variables at baseline that are relevant for a DEXA study. As you can see, the median age in this population was 43. About a third were above the age of 50, and importantly, half of all subjects were female. And interesting also, the majority of subjects here were of white ethnicity. Body mass index was at the upper level of normal, 25, and the breakdown by background regimen coming into the study was consistent with the parent studies. Surprisingly, we saw that the majority of subjects actually in this study reported no current or previous smoking. And at the bottom, you'll see T-scores for both the hip and the lumbar spine, and you can see that about a quarter or so of subjects met criteria for osteopenia. Right, so looking at the primary and secondary endpoint now, so starting off on the far left, you see the primary endpoint of change in bone mineral density between baseline and weeks 48, an increase of 1.34% in the dolutegravir rilpivirine arm compared to almost no change in the control arm, and this difference was statistically significant. Looking at the secondary DEXA endpoint, again at the lumbar spine, you see an increase, an improvement in bone mineral density in the dolutegravir rilpivirine arm to the magnitude of 1.46%, and again with very little movement in the control arm. Now, at the previous CROI presentation, we had shown overall population bone biomarker data, and at that time, we showed that there was a significant improvement in bone biomarker data in the dolutegravir rilpivirine arm upon switch at week 48. And it's really interesting and reassuring to see this consistency in the data here. So looking at the subpopulation here in this DEXA sub-study of subjects switching away from a tenofovir regimen, you see the same picture with positive p-values across the board for all the bone biomarkers. In addition, we did sub-analysis of the primary and secondary endpoints across relevant baseline subgroups, for example, age, sex, BMI, and baseline regimen coming into the study. And for each of these subcategories, we see a much bigger improvement in bone mineral density on the dolutegravir rilpivirine arm. So I'll conclude by saying that the overall parent studies had shown us non-inferiority of dolutegravir rilpivirine at week 48 in the maintenance of virologic suppression compared to standard of therapy. This DEXA sub-study shows evidence of long-term benefits of such a nuke-free regimen in the way of significant reversal in bone mineral density. And this data positions dolutegravir and rilpivirine as a potential attractive regimen for the preservation of long-term bone health. Thank you, and thank you to all the investigators and subjects in this study.
The session is open for discussion.
Christina.
Christina. Yeah, microphone. No.
That's a great question. In case not everybody heard it, the question is around a bigger proportion of women in the study, but also older patients. And do we have data on menopause? The answer is I don't have that data right now. But as you can see, we expect that a significant number of subjects in this study will fit those criteria. And I think it's a really important point you bring up, Christina, because we all know that perimenopausal women, especially white perimenopausal women, start losing about 2% of their bone mineral density longitudinally. So to really see a 1.5% roughly improvement in bone mineral density, I think is quite impactful.
Other comments? Question? Thank you.
All right,
Thank you.
Thank you. So we're coming to the final presentation of this late breaker poster session, which will be given by Victoria Lund from the University of Cape Town, South Africa. And her talk is titled Earlier Treatment and Lower Mortality in Infants Initiating Antiviral Therapy at Less than 12 Weeks of Age in South Africa, the International Epidemiologic Databases to Evaluate AIDS in Southern Africa, the IDEA collaboration.
Thank you very much for the introduction, and thank you to the IAS for this opportunity to present the results of our study. I have no conflict of interest to declare. So just by way of background, as we already know, there has been an expansion of immediate antiretroviral therapy for HIV-infected infants under the age of 5. And in South Africa particularly, there has been a shift towards immediate infant diagnosis and early infant ART. And more recently, in 2015, birth early HIV infant diagnosis was implemented, so we have more infants initiating ART at an earlier age. Nevertheless, we know little about the outcomes of infants starting ART very early, particularly in routine care resource-limited settings in this era of widespread PMTCT and ART. So our objectives were to describe the temporal trends and outcomes of infants starting ART less than 12 weeks of age, and to describe their outcomes by 6 months on ART. Our primary outcomes were mortality and loss to follow-up by 6 months on ART, and we define loss to follow-up as a missed clinic visit between 3 to 9 months on ART. In other words, no clinic visit for up to 6 months. And among those lost to follow-up, we further distinguished between infants who were lost right after the date of ART initiation and those who were lost after at least one subsequent visit on ART. So we assessed median time from ART initiation to death and loss to follow-up, and associations between characteristics at ART start and mortality we assessed that as well using the methods shown. And we described these characteristics and outcomes using 3 guideline periods to capture the context of changing HIV pediatric testing and treatment guidelines. So this is a quick summary of our cohort. We included nearly 1,400 infants, and as we already expect, infants are initiating ART much younger, particularly from 2013 onwards, and we also saw an improvement in the immune status at ART start, with CD4 count increasing progressively over the 3 guideline periods. Similarly, we saw that the proportion of infants starting ART with less advanced disease had significantly declined, and a similar trend was also observed for the weight for HZ scores at ART start. Looking at mortality by 6 months on ART, we see we had mortality was around 6% overall by 6 months, and we saw a decline in mortality. However, mortality was not significantly different between the last two time periods. Loss to follow-up was around 18% overall by 6 months, and we saw a progressive decline in loss to follow-up over guideline periods. And among those lost to follow-up, a significant proportion were lost right after the date of ART initiation. We assessed predictors of mortality by 6 months of ART, and looking at the univariate analysis, we saw a significant association between the time period of ART initiation and mortality. However, when we adjusted for disease severity at ART start and age and other baseline characteristics, we found that there was no longer a significant association. So in conclusion, our results show that children are now starting ART much earlier with less advanced disease and associated declines in mortality, which reflects some of the successes of the South African pediatric ART program. But after adjustment, we found that time period was not necessarily associated with mortality, and we think that improved baseline characteristics of infants initiating ART may be impacting more on mortality rather than time period of ART start. Sorry about that. Sorry. Okay, so, and also a significant proportion of children still start ART with advanced disease, and our estimates of mortality and loss to follow-up remain high. So in conclusion, our studies highlight the need for innovative approaches to ensure that HIV-infected infants starting ART in routine care settings achieve optimal treatment outcomes. I'd like to thank my co-authors and collaborators for their contributions, and thank you for your attention.
Maybe I can start with a question. So if I saw it correctly, the loss to follow-up was different by period of guidelines you were looking at. So why would that change necessarily? So why is the loss to follow-up getting better in the newer era? Yeah, what are the reasons for that?
Thanks for your question. I think the improvement in loss to follow-up could be attributed to a widespread PMTCT coverage. Around 2013, option B+ was implemented in South Africa, and we think this may have contributed to better retention in care over time. Yeah.
The combination of drugs are changed between the period, or it's always the same? You don't tell us the kind of combination between all the period.
Yes, not included in this presentation. The drugs change over time as the guidelines changed as well for HIV infant treatment, but we have not investigated some of the impacts of the changing regimens.
Any more questions? Well, thank you very much.